activity. Special thanks to Dr. Ahmed Al-Jirad, the organizer of this program, and Dr. Salman Sharif, who actually support us in all of our conferences and our science programs. Again, I want to welcome our all members in the neurosurgery to share us in the presence of these activity and to share in the
Dr. Majid have some connection problem. Okay. Okay, thanks, Dr. Majid. I think he has some connection problem. Now, Professor Salman, please, you can give us a brief talk.
Okay, Ahmed, I'm really grateful. You guys have done a wonderful job. I think you have been working hard for so many years with trying to train the young trainees. And obviously, WFNS is all into it. Pakistan Society of Neurosurgeons was the one that was involved all along during the COVID, but they'd be very happy to tag along and make sure that we work hard. I think the other people who are involved obviously are the Yemeni Society and Dr. Majid and Ahmed Al-Jirad. I think you guys have done a great job, and I'm grateful. All we needed to do was support you, and that's our job. And the WFNS Young Neurosurgeons Forum should be a huge asset, and they can learn loads through these different educational activities that you guys are doing, and hope that we can continue with this trend and make sure that we train people in areas where there is not enough facilities or training available, so we get into their home without going there, and they don't need to travel to areas where it costs them money, and obviously it's sometimes difficult. So I'm really grateful to all of you for having done a great job. I'm thankful to the president of the Pakistan Society of Neurosurgeons, Shahid Ayub, who's very kind in helping us. And I think we just need to continue pushing and getting more and more people involved in this. So hopefully you're going to have a wonderful webinar series, and I'd be looking forward to hearing from all these. And I'd like you to carry on. Wonderful. Great job. I'm sorry I couldn't get involved directly and for a longer time because the ISMIS is going on in Germany, and we have an endoscopy week, which we finished. So in another couple of days, we should be done. So hopefully we'll be able to join you from next week onwards. Thank you very much.
Thank you very much, Professor. Dr. Majid Amir.
Yes.
Please.
Salman and
okay. Dr. Shahid Ayub will not be able to join us, apparently.
In the connection.
Yes, no problem with Professor. So maybe now I can see if Dr. Ayub Shiran is also here or no. I think he couldn't join us also. Okay, so now I will share with you my screen and give a brief introduction about the program, if possible.
Yes.
Dr. Emrah, can you please stop sharing so I can start?
Okay, sorry.
Thank you, Professor. Thank you very much. What is it? Can you see my screen? Can you see my screen?
Yes, yes. A little bit zoom out, please.
Sir, it's visible. It's okay.
It's visible or no?
Yes.
Okay. So this giving an introduction about the comprehensive neuroanatomy educational program. Okay. It's a comprehensive and structured program designed to enhance neuroanatomical knowledge that tailored specifically for medical students and neurosurgery residents. It covers both theoretical and practical aspects of neuroanatomy, and it is essential for clinical practice in neurosurgery. What is the aim of the program? The aim of this program is to equip participants with a solid understanding of neuroanatomy and enhance anatomical knowledge with clinical correlations for neurosurgical practice, bridge the gap between textbook knowledge and real-world application in neurosurgery, provide a structured approach to learning through detailed modules covering key anatomical regions and systems. Who should attend this program? This program is targeting mainly medical students who particularly interest in neurology and neurosurgery, and for neurosurgery residents for deepening their anatomical understanding in clinical context. And also, it can benefit healthcare professionals involved in neuroscience or neurosurgery or related fields. This program will consist of 4 different modules. Now we will start with the first module, which will be focusing mainly on head, skull, and spine basics. It will start today, 13th September, and will have weekly webinars every Friday at 4 p.m. GMT time and 7 p.m. Yemen time. The duration will be from 13th September every week until the 15th of November. Here we can see the schedule of the module 1, of the topics and speakers. After that, we will have module 2, which will be focusing on supratentorial brain anatomy and vasculature. It will starting at 3rd of January 2025. It also will have weekly live interactive webinars on Zoom. It will be in the same time, 4 p.m. GMT, and will start from 3rd of January until 7th of March 2025. Here we can see the preliminary schedule of the module 2. Module 3 and module 4 start still in the preparing, but in general, module 3 will focus on infratentorial brain anatomy, like cerebellum anatomy and function, brain stem structures, midbrain, bones and medulla, renal nerves, and infratentorial posterior circulation. Module 4 will focus mainly on the embryology of spine and spinal cord anatomy, segments and tracts, and peripheral nervous systems, including spinal nerves and plexuses. Further details will be announced later, inshallah. This program was prepared by the Yemeni Neurosurgical Society in collaboration with the Yemeni Medical Council and WFNS, Young Neurosurgery Forum, and Dandy Walter, Yemen Student Club, and Neurosurgery Coach, and the Pakistan Society of Neurosurgeons, and also with the Neurosurgical TV of John Brett. So it's a special thanks to all the collaborating societies, especially Dr. Salman Sharif, the coordinator of the WFNS societies, and Dr. Abu Zar Gangur, the chairman of the Young Neurosurgery Forum of the WFNS, and also Dr. Abcherian and Dr. Ahmed Al-Ghanimi, and Dr. Shahid Ayub, president of Pakistan Society of Neurosurgeons. The registration attendance will be available to all who are interested to attend this program through Zoom link. It will be the same link for all the webinars, and the recordings will be available on YouTube at this link, and also, inshallah, soon will be available on Facebook page of the Yemeni Neurosurgical Society. After completion of this program, all the attendees will be given approximately 12 or 11 accredited continuous medical education hours from the Yemeni Medical Council and the collaborating societies if they fulfill the minimum requirements. So anyone who attend at least 70% of the webinars live in Zoom and pass the assessment exam at the end of the module will be giving the certificate. So by this, I conclude the introduction of the program. And now we can start with our distinguished speakers, inshallah. So first, we have a lecture will be given about surgical anatomy of the scalp. Will be given by Dr. Emrah Kagan Yasar. Dr. Emrah.
Thank you very much.
Okay. So yours, Doctor.
Is my presentation, can you see?
Yes, sir.
Okay. Hi, everybody. I am a plastic surgeon from Kocaeli, from Turkey. Dr. Abuzer Güngör is was my classmate from university, and he is responsible for this meeting. I'm a plastic surgeon, as I said, in Turkey. I am a fellow of European Board of Plastic Surgery. I'm interested in reconstructive surgery, skin malignancies, maxillofacial traumas, and other fields of plastic surgery because of being a member of a university hospital. Today, I am going to speak about scalp anatomy and ideal approach for preventing bad scenarios about scalp incisions. It is a little bit common issue of neurosurgery and plastic surgery. This was my presentation plan, but some issues about reconstruction, I cut them because I learned the title. I am starting with the anatomy of the scalp. As you know, scalp have 5 layers: skin, connective tissue, aponeurosis, loose areolar tissue, and pericranium. The skin contains sebaceous gland, and connective tissue contains nerves, arteries, and veins, and it connects the skin to the underlying aponeurosis. The front occipital muscle is attached to the epicranial aponeurosis. It goes from the hairline to the nuchal fold, and there is a temporal fascia on the lateral sides. These top 3 layers, I said, move together. We in plastic surgeons say that the movement of these layers is a pinch test. The loose tissue just underneath this 3 layer allows this limited movement. It's called pinch test. This layer has a structure that can be considered avascular, and flaps are generally easily harvested from this level in plastic surgery, reconstructive surgery. Arterial and venous plexus have connection radially in scalp, and as you know, the emissary veins deepens and crosses the cranium and provide venous drainage to the intracranial venous sinuses through a second pathway outside the scalp. As you know, the lowest layer and the deepest layer of the scalp is pericranium. We also call it periost. The front occipital muscles endings are attached to the aponeurosis, and it's also called as galea. It goes from the hairline to the nuchal fold. The scalp innervation is coming from face anteriorly, and common nerve is 5th cranial nerve. It's trigeminal nerve. Anteriorly from midline to laterally, you know, supratrochlear, supraorbital, and auriculotemporal nerves. And posteriorly, lesser occipital nerve and greater occipital nerve. The vascular plexus is very strong in scalp. Its arterial part is coming from both carotid stems. From anterior to posterior, they are called supratrochlear, supraorbital, zygomatica temporal, superficial temporal, and posterior auricular, and finally occipital arteries. The trigeminal nerve has 3 divisions: ophthalmic, maxillary, and mandibular. Posteriorly, the innervation is provided by cervical nerves. The scalp is innervated by these nerves, cervical 2 and cervical 3. The internal carotid artery supplies the scalp anteriorly from supraorbital, supratrochlear arteries, and external carotid stem supplies it posterolaterally. The vascular plexus makes scalp unique. It was shown in literature that only one arterial and venous vessel and one artery and one vein existence can make scalp viable. And we, our clinic in Kocaeli, have experienced this with a case with scalp amputation. On one side, superficial temporal artery anastomosis by end-to-end technique, and on the other side, with a vein graft to retromandibular vein, only one artery and only one vein makes viable the scalp after the reconstructive microsurgery operation. In this patient, the entire scalp was saved without any circulation problem. These are the pictures of this patient, only one artery and only one vein. So veins are as important as arteries. Supratrochlear and supraorbital veins open into the facial vein as the angular vein. Superficial temporal vein becomes retromandibular vein after parotid gland. They join the facial vein, open into the internal jugular vein in neck. The skin connection of the flap in scalp, if we performed a scalp flap. The dermal plexus, the vascular plexus of the dermis is also responsible for the venous drainage. It contributes to venous return. Therefore, the aspect ratio of the flaps is important. The length and the wideness of the flap is important. I will talk about it. This is an image of lymphatic drainage. It's important for plastic surgery because of the malignancies on scalp. The face part of the anterior part of the ear drains into the parotid gland, parotid lymph nodes, submandibular lymph nodes, and cervical lymph nodes, lymphatic nodes. The behind are ear areas after the ear, behind of the ear, drains into posterior auricular and occipital lymph nodes, lymphatic nodes. Here you see the supratrochlear artery as orange color, and it is the supraorbital artery. They comes from internal carotid system. This is superficial temporal artery, comes from external carotid system. This is posterior auricular artery and occipital artery. The ideal scalp incision is important for neurosurgery, as I talked with Dr. Abuzaginger. On vertex, it's not problem in which way we cut the scalp, because all of the arteries can make the viability of the flaps. Both of them are correct for viable flaps in this picture, green or blue. It's not important for plastic surgery because there are lots of arteries, but of course small incisions which are enough for exposure in neurosurgery, which you perform. The exposure width is if it is smaller, the operation time is shorter. So the design options can change. Not to cut very much does make the operation time shorter. Ideal scalp incisions, if possible, incisions may be inside the hair area. Lots of the procedures you perform always inside the hair area, I know. But I can recommend something as a plastic surgeon that cutting to designing the incisions linear is would be better like this. The multiple arterial supply is better, but at least one arterial stem must be in the flap. Sometimes the linear incisions cannot be enough for neurosurgeons, and they want to perform harvesting a scalp flap to perform the operation more comfortably. The placental flap must definitely include at least one arterial structure. More than one is recommended for wide approach with if we want wider flaps. Here, the light blue design is small whiteness, not large. So the dark blue incision would be better than the light blue one. The incisions design should be parallel to the arterial structures. It's a designing would be better. Parallel incisions to the arterial sources is better. Not the red line design is better. The green is better. Not sorry. If possible, not to harvest a U-shaped design is better because of viability of flaps. Not to limit the options for the other operations. Maybe you can perform the revision surgeries. You need more exposure for the cranium and the maybe brain. This feels more comfortable. So not to decrease the options, we need to make the incisions design parallel to arterial structures, as I can say it as a plastic surgeon. If you really need to work comfortably in a wider area and raise a rectangular flap, I said, a flap with a width not less than its high. Otherwise, venous problems may occur. The green design is better here. It's both of them anterior border is the same, but posterior border, if we can make it wider, the perfusion, blood perfusion would be better. Preparation and attention is important. Why? All of the operations must be done in attention. There are steps that we should not overlook in order to prevent healing problems. Using adrenaline solution before the incision support both comfortable opening and comfortable closing. Excessive use of coagulation may cause partial necrosis and alopecia in the skin. Before closure, washing the field with betadine and saline must be routine. It is my routine. And optimum closure is very important. At this point, no tension or minimal tension is necessary. Layer to layer with eversion sutures make an ideal closure. Most of the neurosurgeons use stapler for skin closure because it's practical, but only stapler is, I think, not enough sometimes. And I use and I recommend it subcutaneous PDS sutures for 4 to 5 centimeters. Per 4 to 5 centimeters, I use PDS sutures subcutaneous. And if necessary, horizontal matrix sutures with Prolen as needed for eversion if the staplers is not enough. Just closure of skin without subcutaneous repair decreases the thickness of scalp, and on the incision area, on late period, we can see the scar spreading and scar depression. Subcutaneous hemorrhages, free hair pieces, and other foreign bodies may cause healing problems, as you know, due to infection. Some of these terms are maybe the termination of neurosurgery. Incisions described as pteryneal incisions, sorry for that, and posterior fossa incisions are seen. If the frontal branch of the superficial temporal artery can be preserved on the left, the advantage would be greater of flap viability on the left side here. Parabolic incision is preferred to avoid the occipital branch on the right one. This is pteryneal craniotomy. This is temporal craniotomy designs. These incision selections are for temporal craniotomy. It's parallel to arteries, and ear area does not lose its blood supply. But I can offer this green arrow to become a wider pedicle proximally if it does not bore you perioperatively, this design would be better not to shorten the whiteness of, we call it in plastic surgery, pedicle of the skin flap. This is frontal craniotomy, as you know. It is for approaching to maybe small size lateralized areas of frontal region, and bifrontal craniotomy for wide and especially for central areas. In plastic surgery practice, we use the term also coronal incisions and bicoronal incisions. And we usually use bicoronal incisions approached for fractures of naso-orbital ethmoid fractures. As you see here is a perioperative photograph of my one case of photograph. This is open reduction and internal fixation of nasofrontal anterior table fracture repair. And another one with the approach of bicoronal incisions here. And the 3D scan photos preoperatively and postoperatively. This is a parietal craniotomy. It can be designed in both ways, occipital to frontal or biparietal as ear to ear. In plastic surgery practice, it's not important. But both of them has the same advantage about number of arteries, as I mentioned before. The posterior fossa approach and or retrosigmoid craniotomy, the terms of the neurosurgery, is a curve or parabolic incision for occipital branch here, and suboccipital craniotomy incision. It's the ideal incision choice for occipital craniotomy. It's the ideal frontal incision. It's recommended that frontal region incisions must be selected within the hair, 1 to 2 centimeters behind the hairline anteriorly, and linear design is always better than U-shaped design incision. An incision design that is not recommended in neurosurgery practice, I think, because the base of the flap is narrow. Its height is planned too much. There is a risk of healing and maybe contraction problems because of circulatory disorders, so if a revision surgery is necessary. Maybe I can offer in here the green arrows to approach the operation area with a wider flap base while having an wide exposure, I think. The scar, after that scar, this incision design, I think it's not an ideal incision if the patient would have another revision surgery. The ideal old incision scar can be easily extended in revision surgery. This initial surgery scar to be created on the patient is important because if necessary, the same incision will be extended in subsequent surgeries to eliminate blood supply problems. The arrows in these photographs should show the old scar, and in revision surgery, the old incision scar can be extended to approach the mass more widely. In the patient who needed a third operation due to recurrence, the approach using the old scar will not provide sufficient exposure. So a design perpendicular to the old scar, which is actually ideal, was used here. The old scar is not ideal for scalp incisions because it's horizontal. It's not parallel to arteries, the old scar you see here in black arrow. It can be said that it was more correct to avoid the U-shaped incision here, because if we perform a U-shaped incision here, like this arrow, big arrow, this red area here, could you see? Can you see here the red area will be totally necrosed or maybe have healing problems. Is there a circulation problem in a flap plane perpendicular to an old scar? We sought an answer to this in a study we conducted in our clinic in an experimental study. Random flaps were harvested, and group 2 and group 4 here. There was a flap on dorsal of the rats, and in group 2, incision on proximal of the flap, and group 4 in the middle of the flap we performed. And after these incisions, we have harvested as group 1 after 45 days. And we see that group 2 and group 4 here. The flaps were elevated and contrast material was administered and arterial supply was compared. We see that waiting after a horizontal incision from the proximal pedicle may create a vascular network here. It's group 2 here. You see the vasculature. In group 4, waiting after a horizontal incision in the midline of the flap is a high risk of vascular network insufficiency. The distal part is more necrosed rather than group 2. In conclusion, when enough time has passed over the old scar, the newly formed vascular network can support the circulation of the flap. However, U-shaped designs are not advantageous in flaps with an ideal aspect ratio. Before planning a scalp incision, we have to know the patient history. Is there an old scar? The previous traumas, surgeries must be known because some of the arteries may be loosened before. We need to know it. It's a patient who have on the left side, who have a parotid surgery and neck surgery, has lose his superficial temporal artery, and so a design with a superficial temporal artery is not sufficient for a flap. On the right one, the posterior auricular side flap used beforely. So you cannot use these parts for a scalp flap. Here, black arrows are old scar, you see, an ideal incision scar history. A new vertical incision can be added for third operation for a wider exposure. And some ideal plans are seen according to the location of the mass. Flap designs may vary depending on the size of the mass and the width of the craniotomy area to be performed in the same region. When planning these incisions, general principles must be followed. Tumor recurrence and second or third surgery possibilities must be kept in mind. The radiotherapy and incompatible incisions will increase the risk of flap circulation disorders. Optimum skin closure have got a great importance. It's I recommend not to forget it. Some of the samples for ideal incision designed for occipital approach here. Skin incisions can be combined with adequate exposure if necessary. However, when making these combinations, wide-angled distal parts of flaps should be preferred rather than narrow-angled distal parts because of the circulation disorders. For a nice wound healing, this is the prophylactic offers. Analyze patients' potential recovery problems and prepare them for recovery. Surgical sterilization at any time. Work really atraumatic for scalp, skin. Do not place multiple foreign bodies in the same area for preventing the infection. Avoid polyfilament sutures if there is a tendency for infection. I use PDS. Prevent hematoma and postoperative compression. The compression can be from inside because of the foreign bodies or from outside because of the position of the head of patient. Apply ideal dressing. Wash, dry, apply pomace when the wound is epithelialized. Prevent stratification, remove stitches on time. The ideal removing stitches time is 10 to 14 days for plastic surgery. It will be the same for maybe neurosurgery, I can say it. In every craniotomy patient whose bone healing is not fully achieved, for example, it's inevitable to encounter discharge, and its cause cannot be immediately found. It is another thing to keep in mind. These are my cases. There was no any infection after the operation, but it is not recommended to use multiple foreign bodies in the same area. We use MEDPOR here, plates, greaves, is a cranial graft, bone graft. It's titanium mesh. It's an use shunt. It's not recommended. When there is no repair in the scalp that is suitable for layers, there will be a depression in the repair area. Scalp stitches can usually be removed, I said, 10 to 15 days. Sutures that are kept longer will increase the risk of infection. Here, maybe we see as very skillful surgery done intracranially. We can think that, but skin is not repaired carefully, or there is a healing problem, which makes both patient and doctor unhappy. Therefore, I hope for neurosurgeons not to lose the satisfaction gained from the careful attention given to intracranial intervention because of poor skin repair. Bed wound healing and management. If you can find the reason because of fluid, or there is an infection or drainage, if you cannot find the reason, there can be no solution. So we have to be realistic. If there is something that we are thinking that it's because of that, we have to do some algorithms, perform some algorithms to procedures. If we have to, we must. Treatment for both bed wound healing or management, I can say, find the problem first. Does the patient have a systemic disease? Is there an infection? Making culture, microbiology culture with swab firstly. After that, in operation, we can make a culture with soft tissue or bone samples. Are foreign bodies infected? We have to know that, and we have to be realistic if there is a CSF drainage. If a fluid comes through an incision scar and we cannot prevent that fluid will inhibit the healing of the wound. Management of the infected scalp is important. We can use prophylactic systemic antibiotics, and I said culture, local dressing change, and foreign body management. If there's a biofilm in the wound, we have to excure it. We have to debridement. We have to perform a debridement. Management of abscess if present, and if there is a bone infection, we have to perform some procedures, for example, debridement. Or if we need a revision surgery, we have to perform. It's the last slide of my presentation. It's my team after a reconstructive microsurgery. Thank you for attention. Thank you very much.
Thank you very much, Doctor, for this nice presentation. Dr. Majid.
Dr. Emrah, thank you for your very thoughtful and precise lecture. And actually, I have a question regarding to the scalp surgery. Sometimes we are facing problems regarding scalp flap. If we have sloughing of the scalp or necrosis of an area of the scalp, how can we if there is a possibility to do a skin flap from the scalp itself, or we have to do scalp from another area? This is the first question. My second question is regarding to the lesions in the occipital loop. We have sometimes difficulties to do a small incision without reaching the occipital loop. Because we are afraid of interrupting of the occipital and retroauricular arterial supply of the occipital region. How can we design the flap in the occipital region with small incisions, as you said? sooner incision has a shorter time for the operation.
I couldn't understand the first question, but the second one is about occipital nerve here.
Emrah, where's my question?
I couldn't understand the first question, but the second one is about the occipital nerve.
The first question was about
Can you, Dr. Ahmed,
if we
can you
face
hear me?
necrosis. Yes, now we can hear you, Dr. Majid.
Dr. Ahmed?
نسمعك دكتور ماجد. Dr. Majid have some connection error. His first question was about if we have a necrosis, how we can manage necrosis post-operatively. Scalp necrosis. How can we manage?
I understand. Before the operation or after the operation necrosis? Yani perioperatively, after the operation, you can consultate the plastic surgeon. The necrosis and debridement and the scalp flap if we need. Not to design a flap, why the scalp flap designing, as the neurosurgeons want to use U-shaped flap design. If you use U-shaped flap design, whiteness is must be equal to length, not more, not much more. The whiteness must be equal to length of the flap. If you perform like this with an anatomic arterial vessel into this flap, you can see, I think, any necrosis on marginal sides of the flap. But if you miss the arteries into the flap, or the basement of the flap is narrow rather than the length of the flap, it's not equal. If it's not equal centimeters, the necrosis risk will be high. Did I understand through the question and answer? Is it okay?
Yes, thank you. Thank you very much. Thank you very much, Dr. Emrah, for your nice presentation. If there's any question from the other attendants?
Sorry?
I see here a question in the chat.
Okay.
I see here a question in the chat. Dr. Hazayor asking about what about the effect of artificial cream or gel in low perfusion area post-operatively?
Sorry, I can't understand. Is it written here? Can I see it?
What about the effect of artificial cream or gel in low perfusion area post-operatively? Is the application of a cream or gels in the scar or
if the patient hasn't got any vascular problematic comorbidity, in our practice we don't use any cream or something. But if there is a venous insufficiency, I can say you can see it with the not ideal flap designs, as I mentioned before. You can see the venous insufficiency, venous problems, distal parts of the flaps. Sometimes if you see it, you can use the technique we use, bleeding the distal part of the flap. We use in plastic surgery practice leads sometimes for the venous insufficiency. Sometimes the venous insufficiency is not very much, so we can use bleeding with scissors or blade postoperatively. This is done. We can perform this in 2 to 4 days. After that, the venous insufficiency may be resolved. But in arterial insufficiency, you can you don't have any anything to do to make it more arterial supply.
Okay, thank you. I have a question, Doctor. In cases if we have a big defect in the scalp, how can we manage in these cases? Because sometimes we have
example,
cases that almost all the scalp area is lost. So what's the options here?
I have some samples of reconstructive surgery. If you have time, I can show you some samples.
I think we have 10 minutes before the time of our next lecture, so I
Okay.
think it will be okay. Okay, you can see here.
Can you see it?
Yes, I can see it.
This is a scalp squamous cell carcinoma. Here, it's a recurrence tumor, and we have resected it above pericranium, and the pericranial tissue have its own blood perfusion, and it is skin grafted here. If there is the layer of the deepest part of scalp, it's pericranium, you know, we can skin graft here. The skin graft lives here with being above the pericranium. If there is not pericranium, you cannot perform skin graft. This patient has a arteriovenous malformation on his frontal region. Here, 2 to 3 centimeter defects. You see, we can solve the problem with primary closure here. 2 to 3 centimeter defects. It is the same procedure in scalp. Up to 3 centimeter defects, we can maybe close it primarily. Here, the first big picture of the same patient. Here, this is scalp squamous cell carcinoma. It's very huge, but on CT scan, we did not see any bone invasion, and we make the resection of this tumor. And after resection, we behave for waiting a granulation tissue on bone. Some places have pericranium, some places don't have any pericranium. So we wait for about 3 to 4 weeks. This wound open. And after the granulation tissue is seen here, we grafted with a skin graft here. This place can be grafted. There is a reconstructive ladder in plastic surgery practice. If the defect is small and if it is superficial, especially we can say if there is a pericranium in skull or in scalp defect, we can wait a little bit secondary healing, or if it is not small or wider, we can make a skin graft here. This is a reconstructive ladder. It is up to up part of the ladder. The operations are more complicated, becomes more complicated. Secondary healing is just waiting for the wound to become more granulate, and after that we close the wound with a skin graft here. Or sometimes I will show it, we can use local flaps on the scalp. For example, here we use the supratrochlear pedicled flap for nose reconstruction. You see, This flap is used here for nasal reconstruction in 2 steps. This flap is an axial pattern flap. Inside it, from here, you remember the anatomy of the scalp at the beginning of my presentation. Supratrochlear pedicle is inside this flap, and distal parts also having the blood perfusion. As a other case, similarly, in the lower eyelid, there is a squamous cell carcinoma, and we resected that, and after that, similar supratrochlear artery-based paramedian forehead flap reconstruct the lower eyelid here. Another patient with neurosurgeons, we performed a squamous cell carcinoma resection, a bone resection, and dura reconstruction by neurosurgeons. And this patient was a little bit old and not enough healthy comorbid. There was comorbidities. We performed a SCALP flap here. You can see here. This patient is in supine position. We designed this flap with the one side of the pedicle is on nasal abrasion, and the other side we didn't cut. It is like that. You see, we harvest all of this part above ear and close the foreign body here, and the donor side is closed with a skin graft. There is another patient. This is a mesenchymal malign tumor of frontal region. We resected. We cut the upper surface of the frontal anterior table, and then we get a free flap surgery. We performed a free flap surgery. We call it in plastic surgery anterolateral thigh free flap, and we use superficial temporal artery and vein to reconstruct this area. This is the pictures at the operation time and after months here. Another patient with arteriovenous malformation on frontal region, we resected that. We wait for a while because of the arterial components of the mass not to bleed, and then after weeks we performed the same procedure as the patient an LAT free flap surgery. Sometimes the defect is very huge. We must use a huge flap. In body, the hugest flap is latissimus dorsi muscle flap. We can reconstruct all of the scalp with this muscle. This patient have a squamous cell carcinoma because of marginal ulcer on skin, because of burn history, resected, and the bone resected, and also dura resected and reconstructed by neurosurgeons. We performed the free flap surgery with this muscle free flap to anastomose to superficial temporal artery and superficial temporal artery concomitant vein. And another patient with no bone here, you see, because of the mass invasion. And we performed an operation with neurosurgeons again. They reconstruct dura also, and not seen here, but we used the titanium mesh again. After that, a latissimus dorsi muscle flap with reconstructed with that, and we are waiting for a while because the reconstructive surgery patients sometimes needs to revision surgeries after the operation in 7 days because of the insufficiency of arteries or veins. And when we are happy with these days, after these days, we can perform the skin graft reconstruction on the muscle flap here. It's all. I can show you the in this presentation. Sometimes if you want to make an SCALP flap with U-shapes, I mentioned in the ideal approach that you have to know that minimally one artery have to be in the flap. We, in our practice, we call it axial pattern flap. If you don't get an artery in the flap basement, it's not an axial pattern flap. It's an random flap. If you perform a random flap very long, it will have and maybe problems, especially in venous insufficiency. You can see the flap at the beginning purple or blue. After days, you will see that the purple area is necrosed. So the design have to be at least one, or if you want to make wider flaps, you maybe design with 2 arteries to be more comfortable. It's all I can say about it. Is there any question?
Thank you. I think there is a question by Dr. Mu'tasam Al-Asali. Dr. Mu'tasam. I think he's not here now. Okay. Thank you very much, Doctor.
Thank you.
I see a question in the chat.
Okay.
What safe area which will healing by this local flap? No. What about local flap for necrosis area as G shape and other? Actually, I didn't understand the question here. You can see the
Okay, I
chat, Doctor.
see.
Yes.
I don't recommend like it is not ideal incisions in scalp. If it is undistally, it is narrowing. A narrow distal part of flap more likely to have problems. Not to use Z-shaped flap would be better. Small incisions and small flaps never will be enough for reconstruction of scalp because of the bone underlying. It will not be enough. I think you have to consultate reconstructive surgery, plastic surgery to make one operation and one solve. It's my recommendation.
Thank you very much, Doctor. Other question will be after the next speech because of time. Before we have our next speaker, I'd like to present Dr. Aib Cherian, if he is here, to give a brief talk as the chairman of the neurosurgery coach. Dr. Aib, are you there?
No, sir, I cannot see Dr.
Dr. Aib Cherian. I think he's not here. Also, Dr. Ahmed Al-Ghanami. Dr. Ahmed Al-Ghanami is a president of the Yemen Dandi Student Club. Dr. Ahmed Al-Ghanami. I can see him, but I don't know if he's... Dr. Ahmed?
Yes, I'm hearing you. Do you hear me now?
Okay, Dr. Majid, you can introduce our next speaker, please. Dr. Ahmed.
Thank you,
Al-Ghanami.
Dr.
How are you?
Dr. Ahmed is going to talk. You are with us, Dr. Ahmed.
Yes, I would like just to say a couple words here. As a president of DAND Yemen and an assistant, special assistant for the global president of DAND Society, I would like, and on behalf of Professor Salim Abdul Rauf, I would like to offer our full support for this activity. Thank you so much.
Thank you, Dr. Rahman. Thank you very much. Can we start with the second speaker, Dr. Ahmed?
I think if Dr. Aib is not here, yes, Dr. Abshiran is here. Dr. Aib, how are you, Professor?
I'm absolutely good, Ahmed. How are you?
I'm fine, thank you, Doctor.
It's a long time that I haven't seen you for a long time. I'm good to see you here.
Thank you, Professor.
What would you like me
Dr. Aib is
to?
the president of the, yes, as a president of the Neurosurgery Coach, one of the collaborating societies in this program, I'd like if you can give a brief talk about the program.
Yeah, so what I have seen of the program, it's an excellent way because anatomy is the basis of any neurosurgical procedure. And it's something that over the years, it would just not really change. So what you're doing is a very noble and really amazing thing. So what I can do is we do a lot of dissections at our SCALP Academy in Karak. So we have the 3D exoscope. So I'll try and see if we can get some 3D videos, if we can get to watch those. If not, I'll get the 2D videos of various dissections that we have, because we have injected and soft cadavers here, soft embalmed cadavers here. So we will do that along with surgeries I can show. So in this way, I'll be more than happy to help, and we'll start educating anatomy and neurosurgery to the young neurosurgeons. It's a very noble cause. Thank you for doing this, Ahmed.
Thank you very much, Professor, for your